This is a presentation discussing osteochondral allograft transplantation of the capitellum for megaotes in a 15-year-old female gymnast with greater than 8 months of lateral elbow pain, having failed conservative management. Here we can see radiographs that demonstrate a large osteochondral lesion of the capitellum. Advanced imaging as well demonstrates lucency deep to the lesion itself and a loose body in the posterior lateral recess. The patient was having ongoing mechanical symptoms, decreasing function, and on physical examination at this point in time had developed 20-degree flexion contracture. Because of this, options were discussed with the patient, which included debridement, microfracture, autograft transplantation, but secondary to the large size of this lesion, which we measured approximately 14 by 10, decision was made to proceed forward with an osteochondral allograft using the megaotes set. The patient was positioned lateral for a diagnostic elbow arthroscopy. Prior to open intervention, diagnostic arthroscopy was performed. The capitellar lesion was visualized and a large loose body was removed from the posterior lateral recess. The patient was then sterilely dressed and drapes were taken down. She was transitioned to a supine position with the operative extremity exposed on a hand table, and a large extensile lateral approach using an extensile Coker approach was performed. The lesion was visualized, debrided, and the radial head was carefully protected and positioned so that perpendicular access to the lesion could be obtained. A 15 millimeter plug was selected and found to be appropriate size for this lesion. A K-wire was placed through the plug to ensure perpendicularity, and the lesion was freshened with the reciprocal reaming set to 15 millimeters with good contained edges and a clean cartilage line. We reamed to a depth of approximately 6 to 8 millimeters and marked this carefully, then found a reciprocal site on a donor allograft lateral hemicondyle, which we contour matched with the 15 millimeter oats set. After choosing our position, the external guide was utilized to set, and a 15 millimeter reamer was utilized to harvest a plug of approximately 12 depth, being careful to preserve the excess cartilage in case we were unhappy with the graft and wanted to try reharvesting a secondary plug. After confirmation of appropriate graft size and contour, the graft was then cross-cut at a depth of approximately 12 millimeters, and the plug was removed and contoured appropriately. Correct orientation and depth for inset were again confirmed and marked, and the plug was recut to the appropriate depth to match the depth measured in the capitellar lesion itself. Importantly, the edges were beveled so as to make for an atraumatic smooth inset. Here's the final plug prior to inset. The K-wire was then removed and the wound copiously irrigated. Pressure irrigation was used to remove all hematopoietic tissue from the recipient and donor site, and a suture was placed in the bed of the wound so as to allow for removal of the graft if it was not positioned appropriately. The graft was hand placed until it was set and then impacted gently so as to be cautious and gentle with the overlying chondrocytes that are viable in this graft itself. Here's a picture of the final product. The graft was stable throughout a range of motion, and then the lateral collateral ligament was repaired with a suture anchor. Thank you very much.